Beautiful. So again, my name is Tyler Burrell. I'm the executive director here at the Delaware HIV Consortium. I did just want to take a moment to thank you all as attendees for participating in this year's PrEP Summit. We've been doing this annually for 3, 4, 5 years now, and there's always something that is changing in the world of PrEP and HIV prevention services. And so we couldn't continue to do the work without having you as interested partners and collaborators with us here. I can't thank the planning team enough, including Suzanne, who's been leading this effort on behalf of the consortium for years now, as well as our partnerships with the Delaware Public Health Association, Medical Society of Delaware, Delaware Division of Public Health, and so many other people that I'm probably forgetting, so I apologize for that. But to put on something like this, it does take some intention and some planning, and this work can't be done without our partners in this work as well. So I hope everyone has a good time here today. And please know that we are ready to here to stand as partners with you as you try to implement some of this work that we're talking about. And I hope in the next couple of years we can end this HIV epidemic. So thank you so much, Suzanne. Thank you so much, everybody. And I look forward to participating in the future.
Thank you so much, Tyler. Without further ado, I'll go ahead and introduce our first panelist, our first presenter for today. Is Jim Dowling, or James Dowling. Jim originally started working for the state of Delaware after serving 20 years in the United States Air Force as a computer network group manager and an accounting technician. He started with the Department of Public Health as a public health statistician, working for the Ryan White and HIV prevention program. And in 2006, James moved on to serve as the health program coordinator with the public health HIV surveillance and the MMP, which is the medical monitoring program. And then Jim served as the HIV epidemiologist for the Department of Public Health and the program manager for the HIV surveillance program and the MMP program and the Delaware Tissue Bank Registry. Very recently, in July 2022, Jim took over as the program manager for the Delaware HIV prevention program. Jim holds an associate degree in applied science, computer information system technology, a bachelor's degree in human resource management, and a master's in public health. Great to have you as usual, Jim. I will go ahead and start your presentation. Give me just 1 second. Slideshow. All right. There you go.
Okay, wonderful. Everybody can hear me okay, yes?
Absolutely, we can.
Okay, good. All right. Well, I really appreciate the opportunity to come on and lend this information out to a larger group here, I think, than normally we would have. Just a little background on this particular presentation. It is a PowerPoint presentation we have been given in one form or another to the Planning Council annually, as is required, not only by our grant, but of course by the consortium charter as well. So we try to make sure that we're always keeping folks up to date on everything that is going on in a manner that is kind of just the facts kind of presentation. I will say that the panel that we had prior to this presentation really covered a lot of the items that fall kind of in the line of this is how we have to react to this data. So I really hope that the data that you guys see here will supplement and guide, frankly. And I would say, before getting started on the presentation, a huge kudos to the consortium group, and most folks may not know that they just came out of putting together, along with a group of partners, the plan for the next 5 years for HIV in Delaware, and I got to tell you, it was a Herculean effort, and on top of that, of course, Suzanne and Tyler and their entire group came together to pull this event together. So wow, what a big effort, and very, very much appreciated, certainly from the public health perspective, and doubly from the HIV surveillance and prevention perspective. And we thank you very deeply from the bottom of our hearts for getting all this work done. I watched it, and I know it was not an easy task. So again, thank you.
Appreciate it.
Yep. We'll start into the presentation here. The primary sources for everything you're going to see throughout this, and unless I make any notes as we go, come from our reporting system here, which is a federally bound system, and it's known as EHARS, or the Enhanced HIV/AIDS Reporting System. It is a large database of continuing surveillance of everybody that has HIV or has been reported with HIV to the state of Delaware, and it works in coordination with the national data set to come up with a whole bunch of different data points, almost endless, really. The second one, of course, is the Delaware Population Consortium data, which we use to of course, garner certain ratios and rates and so forth. And then lastly, the CDC HIV/AIDS surveillance report kicks in some data there. I will tell you before we continue on that this presentation is a partner in terms of the CDC reporting with our every 2-year epidemiological profile that we do here, and we are currently working on an updated one. As was noted beforehand, I have left the epidemiology job with surveillance, but I am continuing in terms of training for the new epidemiologist that took over there. So we are slowly but surely kind of slogging through all of the program that has been done throughout the years of my doing this work, and we hope to be able to put out a product that serves us well and will help along with our kind of midterm planning evaluations and so forth in terms of reporting back where we're at now. So with that, go ahead to the next slide. If you have any data requests that need to come through after this one, and we certainly do get a lot of those, and we always make sure that we get back with folks. This is the information that you can use. Again, my number is 744-1016. And James Dowling at Delaware.com. And you'll see at the end of the slideshow, I also included Charlene Rodriguez, who took over the HIV surveillance program when I moved over to prevention. Some of the data requests that I have seen in the past come in kind of get into some we'll say micro data levels, and we have to be very careful that we're not giving out any identities when we're responding to those. So they may require OCOM approval prior to going forward. Next slide, please. Okay, so this kind of starts diving into where the data was at, and as you guys can see, this is as of December 2021, and it relates. Well, I wanted to go back to the beginning of the thing, but don't go anywhere. But this is the 2022 report, but goes back to data that is 2021 data. So as you can see, statewide by rates, we were looking by prevalence rates, we were looking at 372.86 statewide, and then African Americans far and away the most affected group, racial group that we gauged, 91.77 statewide against that population, and Caucasians 198.58, and then Hispanics 300.57. And again, these ratios are all estimated off of the Population Consortium estimates for 2021. By gender group, males far and away are affected within Delaware by HIV. As you can see, 71% of all the reported cases through 2021. And while females make up 52% of the population, they are 29% of the cases reported through 2021. Next slide. And this kind of gives just a historic background all the way from 01. And I break almost all of these slides out from 2001 because that is the year that we actually started doing straight HIV reporting versus AIDS reporting here in Delaware. But as you can see, we've been very fortunate through 2021 to have a pretty consistent declination in the trend lines across both females and males. Next slide, please. By ethnicity here in Delaware, African Americans by far the most disproportionately highly affected group that there is. 44% of the cases attributed to African Americans in the late 1980s, and that stands at 65% at the end of 2021. And you guys may or may not get my monthly report, which Stacy Bloom is doing now, but you would find that those numbers essentially don't change, and in fact may be increasing amongst the African American group there. And this is despite being 22% of our total population. So it's definitely something very much worth continuing our concentration on. And then this here basically is a wider dispersion in the trend lines that you can see, and effectively shows the same thing that we saw on the previous slide, and that is that our African American groups here in Delaware are the #1 affected group. Next slide, please. And this breaks it down even further, and there is a big point to be made here, and I'll kind of stop here to say as much. And you can see that African American males have been on top all the way back to 2001. A really big point to make here, and I've been kind of saying this for quite some time, is that we see roughly 12–13% of African American male youth within the MSM risk group being represented year in and year out. And every time that I do these averages, they are above 10%. And I generally do the averages based on a 5-year look. I believe that the last time I did it, it was nearly 13%. And so, you know, we would really like to see a very heavy concentration on kind of alerting and educating that group as well. So next slide, please. So 77% reported to us were between the ages of 20 to 49. I know that myself and Janice Heinzen have always made a big point through the years of looking at the teen groups to make absolutely certain that we're keeping a close eye on how those infections are going. Luckily, this continues to be the case, that we're not seeing as many infections amongst the teen groups as we do in other states across the country. So that stands at around about 4% as it is right now. Next slide, please. And you guys can see this is just the general dispersion as I wrote this. And this is all cases through from 2001 to 2021 and how they line out. Okay, for mortality, I used to do quite a presentation on this drug and that drug and why people are living longer, but it really just boils down to this: with the better treatment that we have seen, you know, globally, we're seeing longer lives, and we all know at this point that adherence will serve a person to a very long age, right, and long life. So next slide, please. And this essentially, and this is one of the slides that I actually go a lot further back because I think it makes the point to be able to look at the level of deaths that we had early on here in Delaware back in the mid-90s. And then when combination therapy started, you can see where it fell off and did a little bit of roller coastering along the way. But then pretty much evened out from around about 2010, 2011, all the way out to where we are now. A little bit of a jump there in 2020. We really have made an ultra concerted effort to identify the deaths amongst those we see living with HIV here in Delaware. And we do it in a three-pronged kind of way. So we do matching against the National Death Index. We do matching against the Social Security Master Death File. And we also get all of our local vital statistics data and match against that. So we've been working very, very hard to get that data in a timely manner. Now, you will see that in 2021, we are a little bit behind, but that's only because the matching was done after this report was put together. And I can tell you that the numbers are a little bit closer to what you see in 2019 and 2020. Okay, so this basically looks at the same numbers, only we're looking at by race. I can tell you guys, when you kind of look at the trends across all the groups, and what we have looked at in terms of the infection data, that it's fairly proportional in terms of those deaths. But of course, that proportional number leaves our African American group mostly affected by dying from HIV. So, next slide, please. And this is again the same data. We just broke it up by male and female. And again, it's proportionate. So what does it look like in terms of the deaths that they're HIV related or not? As you guys can see here, 61% of what the data you just saw was in fact directly related. Some of them, of course, 34.63% of them may have died from some other cause, be it a heart attack or automobile accident or whatever it may have been. The 125 that are undetermined kind of sit like that, and it's a very weird look that we get back from the data, because the NDI data is the one piece of imported data that actually assigns the cause of death, and then everything under that is a secondary cause. And that data itself is about 24 months behind. So that 125 is likely a little bit more defined both within the yes or no columns, but you would probably fill them in by perspective of the percentages that you see there. But just note that the undetermined will be in 2 years, and so on and so on. So it always kind of looked like this, but you get a good idea that a large proportion it was because of HIV. Next slide, please. So 47% of all the HIV cases reported in Delaware through 2020 originated through the Wilmington metropolitan area. Next slide. And this gives you a really good idea. So you got your land areas at the top left there, 22% up north, 30% here in Kent County, and then 48% in Sussex County. The population, of course, is more heavily concentrated up north, 58, 18, and 24%. Next slide, please. So what you can see with that is that our total infections as of December 2021 largely follow what you see in the population. So 63% of that is up in the Newcastle area, and that has been very, very consistent, as you guys know, through many years here in Delaware. It's notable that 36% of the total state HIV infections have occurred within the Wilmington metropolitan area, and that 27% of those were in Newcastle County, but outside of the Wilmington metropolitan area. Next slide. So what we're looking at here is really the the picture of those folks who are living here in Delaware, and we do this by county, and then we do it within the Wilmington area. So by Kent County, you can see it's a fairly even dispersion between the MSM and the heterosexual exposure group. I can tell you that the MSM group has been increasing through the years, and the IDU group has been decreasing through the years. And we largely see that, frankly, due to very good programs and very good education for needle sharing. And of course, our needle exchange program has been very effective in minimizing our IDU numbers. Next slide, please. So, and this is basically what it looks like in Newcastle County, a little bit different dispersion amongst the IDU group, but that has been a heavily shrinking group. Again, in more of the numbers been taken up by the MSM group in Newcastle County. Now, it is notable here that when we look at the concentration of the MSM youth of color group that I spoke of earlier, this is where we see most of them up in Newcastle County. So we're trying very hard to energize kind of the messaging amongst that group and do it in a geographic way for Newcastle County. And you can see the rest of the numbers, 36% heterosexual as well. Okay, so Sussex County, really not expected if you know the numbers across these counties. MSM is 61% of the entire HIV positive groups from that are living in Sussex County, 23% heterosexual, and a very small percent, 6% that are IDU. Now, it's notable here that we like to follow, because I do give some data to the Drug Monitoring Initiative here in Delaware, and we like to follow what these numbers look like in terms of things like drug arrest, drug confiscation, and specifically concentrating on elements where they're confiscating heroin or fentanyl products off the street. And it's very, very heavy in Western Sussex County. So we're always trying to concentrate our testing efforts there, and of course our needle exchange efforts there, and really just getting the message out to make sure that folks are being very careful if they're going to be using those types of injectable drugs. So next slide, please. And then this is what you see in the Wilmington metro area, as I promised. So it's almost a fairly even split, 22, 32, 36 in terms of MSM being on top there, and then 32% heterosexual and 22% IDU. Next slide, please. And this is essentially the new infections by risk group as you've seen it come along. And as you guys can see, the MSM infections have been on top for quite a while, with some exceptions where heterosexual exposures have taken over. I will say that looking at much of the data from past years, and given the knowledge that I have in terms of the efforts to reach back to different years and make sure that we have really garnered the best risk information on these folks being reported to us as we can. Some of that you find as the years go on becomes corrective data. So this is not always a static thing. And you may well see, say, for instance, in 2016, that MSM may overcome that when the next time we go back and look at folks who don't have a risk assigned to them yet. So it's always an ongoing look, and we're surveilling these folks as a constant kind of event. Next slide, please. Okay, so this particular slide, we're looking at basically the same data you saw in the previous one. The previous one was everybody, and this one of course, is males. And as you can see, of course, the number one risk group factor here is amongst MSMs. Next slide, please. And then the females, we really just kind of broke these up kind of along the lines of were they sexually infected, or was it straight IDU infections? And as you can see, really from 2010 up till now, the IDU infections have really tapered off. We have the female group really well defined in terms of their risk. And then the larger proportion of them, of course, are heterosexual exposed. Now, you know, they're as truth lends it, there are a good number of those folks that are heterosexual exposed, but they are exposed, of course, by partners that may be bisexual. They may be IDU users. So there can be quite a mix of reasons behind that sexual exposure, but we tend to look at it in a little bit of a compressed way here. Next slide, please. Okay, so this is the one slide where we really kind of take a look at what the national data looks like, and they generally tend to be a year or two behind where we're at, but the numbers ring relatively true nonetheless. So we can see that our distribution of HIV cases, and this is all stages, for Caucasians here is 31 in Delaware and 29% nationally. Where we differ fairly heavily is 50% African Americans here, 40% nationally speaking. And then again, where we differ fairly heavily, 24% Hispanic nationally, and then 9% here. So we don't see nearly the numbers in positives here that or people living with HIV here as we do nationally. And then 7% nationally that are other races, 3% here. Next slide, please. Okay, and as I promised, I added Charlene Rodriguez's information here. Any questions that you have about this data, it'll likely wind up back with me, but I think historically speaking, most folks that have seen this presentation and have dealt with me understand that I do a pretty decent job in making sure that I get back to folks with any answers that I can possibly give out straight away. And that's a promise. And that is what I have.